Welcome to the deep dive. Today, we're really getting into the weeds of molecular genetics. But the goal here is to give you, the most actionable knowledge for managing ENT disorders.
Exactly. We're moving past just describing conditions.
Right, and getting straight into the diagnostic power. To really set the stage, let's just think about the scale here. Something like 1 in 1,000 children is born with a severe hearing impairment.
And in at least half of those kids, the root cause is inherited.
Half. That's a huge number.
It is. And that statistic is really the core reason why modern otolaryngology just has to have a strong foundation in genetics. I mean, the whole paradigm is shifted. And it's very rare now that we see a condition as, purely environmental. So today we're extracting the essential knowledge, focusing on hereditary sensorineural hearing impairment, SNHI, where genetic testing is it's become a routine, indispensable part of patient care.
Okay, so let's lay some of that groundwork. How did we even get here? Because the idea of inherited hearing loss isn't new, right?
Oh, not at all. We're talking authors like Hartman in 1880, Pulitzer in 1887.
Wow, okay. And what's interesting is that back then, the focus was almost all on syndromic disorders. So things like Usher syndrome, Treacher-Collins.
Well, it makes sense. They had other clinical signs. The associated characteristics, like abnormalities in the eyes or the bones, made them easier to spot as something that was being passed down.
They were visually distinct.
Exactly. The recognition was morphological, based on what you could see. But the real game changer was better audiology and molecular tools. That's when we saw the true prevalence.
And now SNHI is seen as one of the most common genetic diseases in your field.
Without a doubt. If we look at profound hearing loss in early childhood, the patterns are actually pretty clear. About 70 to 80% of those cases are autosomal recessive.
So that's where both parents carry the gene, but they're typically unaffected themselves, correct?
Precisely. And then you have autosomal dominant cases, which make up the other 20 to 30%. That's where only one parent needs to have the gene to pass it on.
And those tend to show up later in life?
Often, yes. They're frequently postlingual. X-linked cases are quite rare, only about 1 or 2%. But here's the really key takeaway for any practitioner.
Okay.
Roughly 70% of all hereditary SNHI is actually nonsyndromic. It's just hearing loss.
Yeah.
With nothing else. And that's why molecular testing is so critical. You don't have those old clinical signposts to guide you.
And this genetic influence doesn't just vanish after childhood, I take it. It plays out dramatically with age.
Absolutely. We can't overstate the genetic component to adult hearing loss. If you look at the prevalence of postlingual SNHI, so a hearing threshold over 25 dB, the curve is just so steep.
How steep?
It's only about 1% in young adults, but it shoots up to nearly 50% by the time someone hits 80. Now, obviously, age-related hearing loss is multifactorial. You've got environment, noise exposure.
Of course.
But understanding that underlying genetic predisposition is becoming absolutely essential for any kind of, personalized preventive care down the line.
Okay, let's dive into some of those molecular specifics. I want to talk about dominant non-syndromic hearing loss, the DFNA loci. These are so important for differential diagnosis. Let's start with DFNA1, which is the DIAPH21 gene. What should a clinician be looking for?
DFNA1 is tricky because it often presents in an unusual way. In younger people, you might just see a low-frequency hearing loss.
Okay.
But then you look at their older relatives, and it's progressed to something quite severe. And this specific pattern, it can easily get misdiagnosed as a Meniere-like disease.
But that's a huge point. So you've got this fluctuating low-frequency loss. How do you tell them apart? What's the key molecular difference?
Well, clinically, Meniere's usually comes with more prominent vertigo and tinnitus, but the mechanism is totally different. The DIAPH11 gene codes for a protein called diaphanous, which is basically critical for managing actin polymerization.
Actin, so the cell's internal scaffolding.
Exactly. If that protein is faulty, the whole structure of the hair cells and pillar cells gets compromised, and eventually they just die off. It's a structural failure at the cellular level.
That makes perfect sense. All right, next up, DFNA2, the KCMQ44 gene. This one always feels like the textbook example of how a channelopathy can just wreck hair cells.
It really is. And we see a lot of families with this one. Clinically, it often starts very early, maybe even congenitally, in the high frequencies, and then it becomes a detectable postlingual SNHI. The mechanism is a perfect lesson in potassium homeostasis.
Right.
KCNQ44-4 builds a potassium channel. It's located specifically in the outer hair cells, and its entire job is to get excess potassium out of those cells after they fire.
So it's like a little pump or a plumbing system for potassium.
That's a great way to think about it. And when the gene is mutated, especially with what we call a dominant negative effect.
Where the bad protein messes up the good ones too.
Right. The whole potassium removal system just fails. This leads to a sustained, high concentration of potassium inside the cell, which is, frankly, toxic. And that cellular toxicity is what ultimately causes the degeneration of those outer hair cells.
So understanding that mechanism isn't just for diagnosis, it actually points towards potential therapies.
It has to. You start thinking about how to restore that ion balance.
Okay, before we jump into the purely syndromic conditions, we have to talk about DFNA 39. It's such a great example of how these classifications can get messy.
Yes, DFNA 39 is the perfect misnomer. It's caused by mutations in the DSPPP gene dentin sialophosphoprotein. Now, even though it's labeled DFNA for non-syndromic,
It's not.
it's really not. It also causes dentinogenesis imperfecta 1. So you see these characteristic opalescent discolored teeth, plus a progressive high-frequency SNHI that usually kicks in around age 20 or 30. Clinically, it's a syndrome. It just goes to show how one gene defect can hit different tissues.
Let's pivot now to those true multi-system syndromes where you absolutely need a multidisciplinary team. A critical one has to be Alport syndrome.
Alport is a big one. It's primarily an X-linked dominant condition from mutations in TOCO4A5 TOBs. This gene codes for a chain of type IV collagen.
Which is essential for basement membranes all over the body.
All over. So the classic triad is progressive nephritis, kidney disease, and SNHI. The hearing loss is often high frequency, and it tends to appear right as the kidney function starts to decline.
So for the ENT specialist, what's the most vital piece of counseling you can give that family?
It's about tying the specific mutation directly to the renal prognosis. You'll see blood in the urine, hematuria, starting in early childhood, but the progression, it varies wildly.
Right.
In the severe juvenile types of Alport, end-stage renal disease can develop really early. We're talking before age 31.
Yeah.
So the ENT involvement becomes this sentinel event that can help the medical team predict that timeline and get ahead of the renal care.
Moving to another connective tissue disorder with huge otologic impact, osteogenesis imperfecta, or OI type I.
OI type I. It's known for relatively mild bone fragility and one very distinctive clinical sign. 100% of patients have blue sclerae. The whites of their eyes are blue.
And for ENT, the impact is massive.
Enormous. Hearing impairment is in about half of patients under 30, but then it just skyrockets to 95% in the elderly. And crucially, the loss is almost always mixed. It's both conductive and sensorineural.
Okay, let's unpack that mixed loss, because that's where treatment can really be targeted.
For sure. The conductive part is often from the stapes bone becoming immobile, which looks a lot like otosclerosis. And that can often be fixed surgically with a stapedotomy.
But then there's the other half of the problem.
Right. The sensorineural component is caused by actual ossification and degenerative changes in the otic capsule itself, the bony labyrinth of the inner ear. For that, you might try pharmaceutical options, maybe fluoride therapy to try and stabilize the bone, though its long-term success is still debated. You have to treat both parts.
Let's wrap up this section with Pendred syndrome. This is a classic diagnosis that's so often confirmed with imaging.
Yes, Pendred. It's from mutations in SLC26A44. It links moderate to profound prelingual SNHI with a variable goiter in the thyroid, although most patients are actually euthyroid.
And the imaging is what gives it away.
The imaging features are pretty much pathognomonic. You're looking for hypoplasia of the cochlea, what we call a Mondini malformation, and an enlarged vestibular aqueduct, or EVA. You see EVA in over 80% of patients. The hearing loss can be progressive, and notably, it often fluctuates, which can be really tough for patients.
Okay, so with all these syndromes, we know cochlear implantation can be a great option. Usher syndrome patients, for instance, do really well. But what happens when the anatomy is already compromised? What are the big surgical risks you have to look for on pre-op imaging?
This is where pre-op CT and MRI become non-negotiable. First, you have to check the cochlear lumen. Is there enough space for the electrode? Second, you must rule out eighth nerve aplasia, especially in syndromes like CHARGE. But the really high-risk details are structural. Because of the malformations, there is a shocking 40% incidence of a cerebrospinal fluid gusher during surgery.
40%? That's massive. Why does that happen?
Basically, the malformation creates an abnormal open connection between the subarachnoid space around the brain and the paralymphatic space of the inner ear.
There's direct line.
A direct line. When you open the cochlea, That pressure gradient forces CSF to just pour out. Pre-op imaging is crucial for spotting the signs, like the EVA. If you anticipate it, the team can prepare to manage it. And on top of that, there's a 16% risk of an aberrant facial nerve course.
Meaning the nerve isn't where it's supposed to be?
Not at all. And a surgeon has to know exactly where that nerve is before they make their first move. Only imaging can tell you that reliably.
So far, we've mostly stuck to Mendelian inheritance. Let's switch gears to mitochondrial defects. These are inherited just from the mother, and they tend to hit organs with high energy needs. And the cochlea is definitely one of those.
The cochlea is a high-performance organ, absolutely.
Yeah.
It's incredibly vulnerable to defects in what we call oxidative phosphorylation, or the OXPHOS.
The cell's power plants.
Exactly. A key non-syndromic example is the MTRNR11 mutation, M11555AG. This one's really significant because it alters a binding site for aminoglycoside antibiotics on the mitochondrial rRNA.
So this is a huge red flag for drug sensitivity then.
A critical one. It means that otherwise safe, common antibiotics can trigger or massively accelerate hearing loss in people with this genetic predisposition. Screening is vital. Then you have syndromic examples like Kearns-Sayre syndrome or MELIS, which involve widespread neurodegeneration on top of the SNHI.
Okay, now for what I think is one of the most fascinating genetic puzzles in our material, genomic imprinting, specifically with head and neck tumors.
Ah, yes. Paraganglioma type I, or PGL1, caused by mutations in the SDHD-DUDO gene. It's the most common type of inherited paraganglioma, these slow-growing, very vascular tumors. But its inheritance pattern is the real stunner.
It's autosomal dominant, but
it has zero penetrance after female transmission.
Wait, say that again. Zero penetrance if it comes from the mother. So if a mother has the faulty gene, her kids are fine. But if her son passes it on, his kids could get the disease.
That's exactly it.
So it just skips entire maternal generations. It must look completely sporadic in a family tree.
It does. The phenomenon is called genomic imprinting. The gene's expression depends on which parent you got it from. For SDHDG, the maternal copy is essentially silenced. The disease only shows up if you inherit it from your father.
So what does that mean for screening, if it looks sporadic so often?
It means you have to be suspicious. A high percentage of what look like one-off paragangliomas are actually inherited SDHED mutations. Counseling has to be rigorous, and we strongly recommend pre-symptomatic MRI scans for anyone known to carry the mutation to catch these tumors early.
And just to round things out, let's touch on one more, moving just beyond otology to rhinology. Rundu-Osler-Weber syndrome.
Rundu-Osler-Weber. It's an autosomal dominant vascular dysplasia. The hallmark is multiple telangiectasis. For ENT, the main thing is recurrent, often severe, epistaxis nosebleeds. This is the very first symptom in 95% of patients, usually starting around age 12. But managing the nosebleed is just the start. The critical point is recognizing these patients are at high risk for visceral involvement, AVMs in the lungs, lesions in the brain. They need rigorous screening. The nosebleed is truly just the tip of a systemic iceberg.
We have covered so much ground today, from, common SNHI subtypes like DFNA2 and its potassium channel, to these really complex, actionable disorders like Alport, and then the whole genomic puzzle of PGL1. It's so clear that genetics isn't just descriptive anymore. It's giving us truly actionable data.
That really is the bottom line. For you, the modern practitioner, it's not enough to know which gene is involved. You have to understand the physiological effect of that mutation.
Right.
Knowing that KCNQ44 messes with potassium, or that TL4A55 is about the basement membrane. That's what lets you predict prognosis, like we talked about with the Alport renal timeline.
Yeah.
And that's what's going to lead us to future targeted therapies. You have to move way beyond just treating symptoms.
So to really bring this all together, think about the clinical implications here. Imagine a patient with known type I osteogenesis imperfecta walks in. They have the classic blue sclerae. You now know their hearing loss isn't simple. Their connective tissue defect is causing two separate problems: the conductive loss from the stapes and the sensorineural loss from the otic capsule itself. And that molecular understanding is what dictates the combined surgical and maybe pharmaceutical strategy they're going to need.
That's the challenge for you to take away. How will you use this molecular knowledge to guide your counseling for, say, a young patient with high-frequency SNHI who might just be showing the first signs of Alport? That's your mandate for the next deep dive.